Hey y'all, how are you doing? I'm great. Thank you so much for asking. It's me, Kim, and I'm back for another video. This video is going to be about Black people and COVID-19. If you watch the news, if you've taken a look at any of the statistics, then you know that this novel coronavirus has had a devastating impact on Black communities all across this country. That is deeply, deeply upsetting because these racial disparities that we're seeing in outcomes, they're not inevitable. This is the result of mass inaction from our governments for years and years and years. It's the result of a structurally racist healthcare system. It does not have to be this way. But of course, I am not a doctor. I am not a researcher. So I sought one out. I had a great conversation with Dr. Uché Blackstock. She is the former associate professor of emergency medicine at NYU. She is currently a practicing physician. In New York right now, she is seeing COVID-19 patients. And it's hard and it's complicated. And I had this conversation with Dr. Blackstock and I did not come away from it feeling great. But the facts are the facts. We have got to change these structures. And a part of this conversation that I thought was particularly interesting was when Dr. Blackstock explained to me how hard it is to be a Black woman in medicine, how difficult it can be to call out structural inequality in systems that are resistant to change. And she has a very unique experience. Her mother was a doctor. She has a twin sister who is also a doctor. So that's where we started. Here's our conversation. Did you ever want to be anything else?
No, which is so crazy. Although I will say, if my children, I have a 3 and 5-year-old, and if whatever, 15 years from now they came to me and they were like, I want to be a doctor, I would say, we get to have a long conversation.
Oh, that's it. Okay, so this is not really what this interview is supposed to be about, but I am curious about why you would say that.
Because I think that what I definitely think as a child I romanticized what being a physician was, but I also think that it's changed a lot, especially with health insurance companies, and they have so much power, and the relationship between you and your patients, the dynamics have shifted because it's all about reimbursements, and you have to see patients quickly and how many patients you see. And it really depersonalizes the whole experience. And I think a lot of us who go into medicine and who want to become physicians, and especially for myself with my mom as a role model, I thought of it as like the best way to serve my community. Like, what better way to take care of the people that look like me and make sure they got the best care. But there are all of these barriers in the way that prevent you from actually getting that done.
Yeah.
Yeah. And then you end up with a whole bunch of debt in the process.
Right. I think I saw some tweet about a physician who had $400,000 in debt. I mean, that's unfathomable for most of us.
I know. Yeah. No, I mean, there are a good number of people. I think I would say, I don't know what the average debt is, but I know probably around 200,000.
Yeah. Still a lot.
It's still a lot. And then with interest and compounding and all that. So, yeah.
Is that why you decided to go off and kind of do your own thing?
Oh, no. So it's interesting. So actually, I was in academic medicine for the last 10 years. I was associate professor. I was promoted last year of emergency medicine at NYU School of Medicine. And actually, I wrote an op-ed piece about it. I'll send it to you. But if you Google me, it'll come up, because my departure was kind of a big deal, just because, these environments are so incredibly hospitable to us as Black people, right? Like, many of us were there because we know we need to mentor our students and our trainees. We're there to do disparities work. We're there to do diversity, equity, and inclusion work. But the fact is that these institutions, they don't really want us to make any significant progress. They really just want us there to say that we're there. Mm. And I was in a leadership role at NYU School of Medicine within doing diversity work. And it just became untenable for me, because I felt like I could not do the work that I wanted to do in that space authentically. And people were trying to censor me, censor our Office of Diversity Affairs, like the content that we put out to the medical school, basically, old white men thinking that they know more than us. And so I just said I couldn't do this, but I had actually in that process started my own organization, Advancing Health Equity, to deal with issues of health disparities and health inequities. And so it's interesting that all of this is coming out now in the pandemic. I mean, this is stuff that I think many of us in the health equity space could have predicted. But I left so that I could focus on my organization, and because I was just tired of dealing with that bullshit.
Yeah. Yeah.
Pardon my language. I feel like
that's really legitimate. And I think that Black women in all kinds of fields express similar concerns.
Absolutely. And what's interesting is that I had been there for a while. I had been there almost 10 years, and I was doing mostly medical education work. I would do diversity work on the side if the office needed me to help. I mentored, I spoke on panels, whatever reception they had, I was always there. I mentored a lot of the students. And so, but once I was officially in the office, and I started speaking up, right? That's when they had a problem. And so I think that's something that's very common.
Yeah.
It's sort of like, you're the golden child, right? Until you actually start speaking the truth, right? And then once you start speaking the truth, yeah, they're like, you gotta go, or you have to be quiet.
Yeah. So we are in the midst of this global pandemic, and just based on what you've already said, when we've been bombarded and inundated with data about racial health disparities in light of this pandemic, I'm sure you weren't really surprised when that data has come out.
Absolutely not. Absolutely not. I actually wrote a piece. I wrote a piece in March, early March, even before we had some of the preliminary data on the racial health disparities. I wrote about why Black folks were going to be incredibly vulnerable to COVID-19 and why we would see the numbers that we're actually seeing now, right? Yeah. It was predictable.
Yeah. How so?
It was predictable and preventable. I mean, just so, even before this pandemic, despite advancement in health technology, innovation, we've had these racialized health disparities that have persisted for decades. I mean, our communities have the highest asthma rates, obesity rates, diabetes, hypertension. We carry such high chronic disease burden. I know you know about the Black maternal mortality rate. Our women are dying in and around childbirth at rates higher than Mexico, where half the population lives in poverty, right? Our babies are dying at rates worse than during higher rates than during slavery, before slavery ended, compared to white babies, right? And so I knew that our communities were in crisis, right? And so really only the people that actually care about our communities in crisis kind of acknowledge this. Right. You know what I mean? Like, so I'm sorry, even though those numbers are out there, it's almost like we're in our own, echo chamber, talking to each other about these health disparities and health inequities. And so one thing that I did notice, and it was so interesting because, I have my organization, but I'm also working part-time in urgent care because I still wanted to keep my feet, even though I'm an emergency medicine trained physician, but I wanted to shift to urgent care because I could just do 1 or 2 shifts a week, keep my feet wet in terms of my clinical practice. And urgent care is usually much more minor complaints. So like I have a sore throat or I have a cut on my hand. But what happened over the last month since the pandemic started and hit New York City, we just started seeing sicker and sicker people in urgent care. But also I started noticing that our patient population, which was typically very racially and socioeconomically diverse, was basically becoming blacker and browner. Wow. And most of my patients were essential workers. They work, I work at some sites in central Brooklyn. They're mostly, they work for MTA, so they're transit bus drivers. They work for corrections. They work for U.S. Postal Service. And so, there were people who were, despite, being told that we have to physically distance and stay home to stay safe, were people who had to go to work. Yeah. And they're at work. They don't have adequate personal protective equipment. They're telling me, even during their visits, everyone at work is sick. I'm scared to go to work, but it's almost like, we are vulnerable for so many reasons. We carry this high chronic disease burden that it turns out makes us more susceptible to serious complications from COVID-19. we are exposed because we are in jobs that put us on the front line, so to speak, of the pandemic, right? And then even in terms of testing, we know that there is limited testing availability, right? Like United States, we were behind the 8 ball because of ineffective federal leadership, the bureaucracy of the Federal Drug Agency and CDC. And so, and I always commented on this, that when we first started testing people at my clinic, the criteria that we were using, I felt like almost discriminated against, working class Black and brown people, because you needed to have traveled to one of the endemic areas, so Italy, China, or Iran, or you had to know someone who had been tested. Okay.
Right.
So it was very unlikely that my patients were traveling or recently traveled to any of those countries, right, or knew someone who had been tested, because up until that point, most of the people who had been tested were people who we heard about on the news, who were celebrities, right, or politicians, or, or someone from some affluent background who could easily connect with a private company that had testing and could arrange testing, or be part of the Utah Jazz team where everyone got tested, and the Utah Jazz, yeah, and no one had even had symptoms, right? And so, that made it very clear to me, like, who had access to testing and who did not.
Yeah. So you touched on something that frightens me. You're in New York, where it seems like your governor is a reasonable person when it comes to this pandemic. Right. We'll say that. But there is talk about reopening the economy across the country. And I get concerned because the people who are going to be primarily exposed are working class people. And we know about the intersections between race and class and gender and class. Does that worry you?
Oh, yeah, absolutely. And it's so interesting seeing the people who are protesting in favor of the reopening, and how they look nothing like the communities that are being most impacted disproportionately by COVID-19. I understand that the importance of making sure people have jobs and that people are able to bring home some source of income, right? So that, I guess, that is the argument for opening businesses up again. But I also understand the human toll, right? And I've seen the human toll. And I have to tell you, I have been practicing for 15 years. I have never seen such sick people before. This virus is particularly nasty. It's very scary. I've never been afraid to go to work before. I'm afraid to go to work. Yeah. And so if we do have strategies in place, like what's being done in most states, some states are not really doing shelter in place. But if we're seeing, like in New York City, we're seeing that flattening of the curve. We're seeing that the rates of admissions to the emergency departments for flu-like illnesses like COVID-19 are flattening out, plateauing. That's a great sign. Yeah. I mean, that is such a great sign. And so I think we need to just, do what we need to do right now, reassess in 4 weeks. And I think this also speaks to the fact that, our local, state, and federal governments are so ill prepared. Like, so if a crisis is going to happen and people are going to be out of work and small businesses are going to need loans, then, these are things that should have been thought about previously to this, right? Or prior to this, not now.
Yeah. So let's talk about the governmental response here. The White House seems to be very comfortable with the narrative that Black people who are often hardest hit in their communities just need to make better choices. Mm-hmm. And if we just made those better choices, we would be less likely to die from COVID-19. I'm not a doctor, didn't go to medical school, but that seems like an oversimplification. Could you talk a little bit more about that?
Oh, yeah, absolutely. I cringed when I heard the Surgeon General, Jerome Adams, say that at that press conference. It's such a lazy and inaccurate response. And, there are folks, researchers, like epidemiologists, public health researchers who have been doing this work for a very, very long time. And we know that factors like poverty and inequality, access to safe housing, access to quality education, we know all of those have a larger influence on a person's health status and their health outcomes versus individual habits, right? Mm-hmm. And so for the Surgeon General to present that idea is just really, really sloppy and incredibly, as I said, in an accurate way to make a point. And so I think that what we're seeing now just calls even more attention to some of what we call the social determinants of health. We know some of the ones I mentioned. So housing, employment, education, access to healthy foods, access to healthcare. All of those factors are so important to someone's health. And we also know that structural racism is a key driving force of those social determinants of health. And so in response to what we're seeing now, it requires an explicit and intentional effort to address those factors, right? It's not going to be easy, right? And that's short term and long term. But what I think could be done now, short term, is we need to focus resources and energies on Black communities. I think we know that testing is very important. So we need to target testing to the communities. We need to work with community-based organizations in those neighborhoods so that we can make connection with the people who have been doing this work for decades, because it's one thing for, I don't know how many people are going to listen to Jerome Adams, right? People are going to listen to people that they trust and love, is whether there's their pastor or the coach or someone who the community reveres, right? And so we need to really make that connection. We need to make sure that there are adequate healthcare workers, personal protective equipment, ventilators in the hospitals that serve our community. And then for those of us that are essential workers, we need to have personal protective equipment for them. They need to receive hazard pay, financial support, right? Whether it's childcare, like we need to support the people that really are what it's so funny that it's been revealed, quote unquote, that these are the people whose work is the most important, right? When I'm sure that they and their families always knew that, right? Yeah.
Right. Yeah. And they've been continually trying to fight for a fair wage, a living wage, and people in control have consistently denied them that. And now they're essential.
Exactly. Yeah. Exactly. And they don't have the luxury of working from home. Yeah. So that's what I saw in my practice over the last month, just so many essential workers coming in. And I saw less white and affluent patients who are working from home because they've been working from home. So they haven't been exposed. They're not coming in with symptoms. They've basically been protected.
Yeah. So a whole lot of stuff goes into public health. Could you talk a little bit about the connection between residential segregation and the racial health disparities that we're seeing in this pandemic?
Oh, absolutely. I mean, it's so funny because I don't remember who said this, but I think all of these, the disparities, many of them boil down to residential segregation, because when you have communities that have been marginalized and disinvested in, you have communities that have poor health outcomes. So even thinking about the communities where there was redlining in the 1930s, right? And where folks could not take advantage of the GI Bill, or where highways were run through, you can actually put, in New York City, for example, and even in Cleveland, all the major cities, you can put a map of the redlined areas that received the lowest ratings, like C and D ratings, those neighborhoods that were mostly inhabited by Black folks. And you can put them over the areas that now, present day, have the shortest life expectancy, highest asthma rates, highest diabetes rates, like the worst health outcomes. And they lay over those areas perfectly. And so, like, what people don't realize is that these historical practices and policies have current day effects on health outcomes.
Yeah. All right. Speaking of history, I get concerned because I see a lot of misinformation being proliferated among Black folks, on social media, Instagram, Twitter, memes about 5G, memes about don't get the vaccine.
I know.
And stuff like that. So how do we combat distrust of government and distrust of healthcare officials that is rooted in real historical facts? How do we build that bridge?
I know. I tweeted about this yesterday, actually, because that distrust is well-founded and absolutely valid. I mean, even thinking about there's a doctor called J. Marion Sims. I don't know if you've heard of him. Mm-hmm. Yeah. So he's considered the father of modern gynecology. He just developed the vaginal speculum that every women experiences, use on her during her gynecologist appointments. But, he also experimented for these very painful procedures on Black women who were enslaved, right? And so it's not even, people talk about Tuskegee. It's not even Tuskegee. It's like centuries before Tuskegee, right? And so this distrust is so deeply rooted and a symptom of structural racism, right? And so, but again, and that is going to prevent us from interfacing with the healthcare system, because even I see it with my own patients where I work in urgent care, and those that are on the sicker side with COVID, I tell them, you may have to go to the emergency department. I may have to send you now, or I'm going to give you these warning signs to go. And they're like, no, I'm not going. I don't want to go there and die. Those doctors aren't going to take good care of me. And you know what? Sometimes I have to just sort of step back and say, I understand. I understand where you're coming from. So this is one of the reasons why I say any targeted approach that's going to address some of the disparities that we're seeing now with COVID-19 is going to have to involve community-based organizations. It's going to have to involve churches. It's going to have to involve, community health workers. Really, and it's not even educating, but having a conversation, right, with folks in the communities about these concerns, because they are so valid. But the fact is that if your oxygen is low because you have a viral pneumonia from COVID-19, staying home is not going to help. You're going to need that oxygen at the hospital, right? Mm-hmm. And so typically I tell people, bring someone you love, a close friend, someone who can help advocate for you. But the problem that we're having now is that when in the emergency departments, they're only allowing the patient to go in. They're not allowing anyone to go in with the patient because of fear of transmitting the virus. So people are FaceTiming. So I would say, take out your phone, try to FaceTime, have your family member FaceTime with a doctor. Make sure you have someone else that you can have ask questions for you. Make sure you're on the phone with them, because the fact is when you're sick, it's hard to advocate for yourself. All right. So I think there are little things that we can do to really help support us, during these times of need. And then, like I said, the education needs to be more of a conversation between public health organizations and the communities.
Yeah. What exactly is the connection between weight and vulnerability to COVID-19? I've heard some conflicting stuff.
You know what? To be honest, I don't know exactly what it is. I don't know if it's that patients with obesity tend to have diabetes and hypertension, and those are more predisposing to the serious complications of COVID-19. I'm not sure exactly. I think there's so much about the virus that's still unknown, but definitely obesity. And that's actually one of the reasons why we're seeing in the United States younger people being having serious complications from COVID-19 more so than in other countries, because we have people who are younger with diabetes or with obesity or with hypertension in their 20s or 30s.
Yeah. Do you see any differences between the issues that affect African Americans in the way that Black immigrant groups are able to navigate this disease or respond to it, or are Black people across the diaspora, are they equally vulnerable?
That is such a great question. I think that it's a little bit complicated. I think that it's interesting. So there's a study looking at Black women and maternal mortality. And they found that Black immigrants, when they first came to the States and had a baby, the babies did well. But the generation after, those babies were lower birth weight and the mothers had increased risk. So it's just sort of living in a racist society. And so I would say that definitely, I'm sure Black immigrants also encounter limited testing availability. They encounter provider bias. They encounter hospitals that have worse quality of care. But I do think probably those of our communities that have been here for generations, probably the overall health of those communities is probably a bit poorer.
Yeah.
But what's interesting is that I've heard from my Caribbean patients, they often talk to me about different herbs that they're taking that have helped them fight the virus. And I'm like, you know what? I appreciate that. Like, if you feel like that is helping you, but I also definitely still want them to seek care as well. But if they feel like that taking that garlic is helping them, then so be it.
Yes, you see that all across the internet. Take your elderberry syrup and the herbs and all of that. I mean, could it hurt? It can't hurt, right?
It can't hurt. If it doesn't hurt, then I'm like, because also, I think a lot of physicians, and myself included, we have a very, very westernized, education. And so the elderberry and garlic, there's been no randomized controlled studies of those. So who knows? They may be helpful. So I'm just said, go ahead, take whatever you think would be useful for you.
Yeah, right. So beyond having somebody there to advocate for you or making an effort to advocate for yourself, are there any other things that you suggest Black people do to help us navigate this after we get it or before we get it?
I would say definitely before and I know this is hard. So that's why I kind of feel like, say, the typical public health intervention. So definitely washing hands, I think a lot of people can do, although there may be some of us in housing, but we don't have clean water, right? Running water.
Right.
The washing the hands is important. The physical distancing is also important, but because we're more likely to live in housing that's crowded.
Right.
And so that is also very challenging for us. And so, but I would say is that if you don't have to go out, so, if you don't have to go out to be in, other than to run errands, then try to stay indoors. Like, you don't have to go to church, can wait. Any large group gathering can wait. I heard about a funeral recently that like 20 people went to, and they all got infected. So the funerals, I know it's so hard because you want to say your proper goodbye to your loved one, but it's too dangerous.
Yeah, right.
It's too dangerous. Absolutely.
Yeah. My mom recently went to a Facebook Live funeral, and it's devastating and sad, but you gotta be safe. You have to be safe. Yeah.
I know. And so while I think there are little things that we can do, I would say, and that largely the other factors are factors that, the state departments of health, local state department of health, our federal government, it is their responsibility.
It's structural.
Absolutely. It's structural.
Yeah.
It is structural. And I don't say that to disempower us, but, I say it to bring attention to these issues.
Right. Well, thank you so much. I appreciate you enormously.
Oh, yeah.
Well, that was it. Thank you so much to Dr. Blackstock. Her time is limited here because, again, she's an actual doctor who sees actual patients. So those 30 minutes were greatly, greatly appreciated. Be sure to like, share, and subscribe. Leave a comment. Hit me up on Instagram or Twitter. Buy some merch. Sign up for the email newsletter. It is still coming. I know. Shout out to the patrons. Shout out to the members. Y'all keep For Harriet going. For real. Thank you so much. Wash your hands. Be kind to essential workers. Practice social distancing, for God's sake. If you can. I know all of us cannot, but do it if you can. Take care of yourselves, you guys. I'll see you next time. Bye.